Good morning, good afternoon, and good evening. I'm Sylvain Gaillard, Head of Corporate Medical Marketing at Sigvaris Group. And with this, I'm really pleased to welcome you to this further MOH webinar with the topic Cancer-Related Lymphedema, Prophylaxis and Management. We will have two really interesting presentations around this topic from two well-known speakers, and followed by possibilities also for you as an attendee to ask questions. And we have also some poll questions for you where you can also test your knowledge about the presentations that you just have heard before, and very interesting topics to discuss with that. I'm extremely pleased to introduce our guest moderator, Professor Szuba. Dr. Szuba is currently Professor of Medicine and the head of the Department of Angiology, Hypertension and Diabetology at the Wrocław Medical University in Poland. He's specialized in internal and vascular medicine. His primary clinical and scientific interests are lymphatic disorders, peripheral arterial disease, and venous thromboembolic diseases. He's the past president of the International Society of Lymphology and the founding member of ILA, the International Lymphedema Association. In Poland, he's the president of the lymphological chapter of the Polish Phlebological Society and the past president of the Polish Angiological Society. He has published over 240 scientific papers and book chapters. His citation index is 7,320. Dr. Szuba is vice editor-in-chief of Acta Angiologica and also on the editorial board member of the Journal of Lymphatic Research and Biology. Andrzej, I'm extremely pleased and honored to have you here and supporting me in moderating this event. With this, I would like to hand over to you and for the first introduction of the first speaker and also for the introduction of the expert panel.
Thank you very much for inviting me to this wonderful event. And it's really my pleasure to see all of you here. And I have a pleasure to present the first speaker. The first speaker is Dr. Vincent Paramanandam. He's lecturer at the University of Sydney. He's qualified cancer case specialist and certified lymphedema therapist. And his most recent randomized trial proved that prophylactic use of compression sleeves reduces arm swelling in women at high risk of breast cancer-related lymphedema. This trial was published in the Journal of Clinical Oncology and is in the top 5% of all research outputs scored by Altmetric. He also was recognized with distinction from the Oxford Brookes University and the Paper of the Year award from Journal of Physiotherapy. So Dr. Vincent is the first speaker, and also we have wonderful expert panel member. And I will briefly introduce everybody. And first is Orsi Kokai. She's a physiotherapist specializing in cancer care and lymphedema management for over 20 years, delivering patient care in Germany and Australia. She's founder and director of Oncology Recovery Services in corporation in Sydney-based multidisciplinary cancer rehabilitation center. Orsi contributed to the understanding of compression use for the management of lymphedema by completing her higher degree by research masters at the University of Sydney in 2020. Her thesis focused on investigating interface pressure applied by garments in the secondary upper limb lymphedema. She is a long-standing member of the Australasian Lymphology Association and is part of editorial committee for their medical journal. And another member of expert panel here is Dr. Margaret McNeely, and she's a professor in the Department of Physical Therapy at the University of Alberta and the jointly funded position with the Department of Oncology, Cancer Care Alberta. She's also director of the Cancer Rehabilitation Research Clinic at the University of Alberta. And her research explores the benefits of cancer rehabilitation and exercise intervention for cancer-related impairment of pain, fatigue, and lymphedema. Also, I'd like to introduce Nouf Aldhwayan, and she is outpatient supervisor of the physical therapy department at the King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. Clinically, she oversees patient care for lymphedema and breast cancer patients. On broader scale, she also oversees the training and competency development of the lymphedema therapists. And I will talk a little bit more about Pinar because she is also a panel member, but she's the next speaker. So I will talk more about Professor Pinar Borman in our next introduction. Thank you.
So yeah, I'm going to present the prophylactic use of compression sleeves reduces the incidence of arm swelling in women at high risk of breast cancer-related lymphedema. And I would like to extend my thanks to the entire Sigvaris team and Professor Szuba for the kind introduction. And so arm lymphedema is common following axillary lymph node dissection. And once established, reversing this condition is challenging. Hence, preventing arm swelling is important to avoid persistent arm lymphedema, associated tissue changes, and poor quality of life. Preliminary data suggest that the prophylactic use of compression sleeves can reduce arm swelling. However, it needs to be confirmed. Hence, we conducted this trial to determine whether the prophylactic use of compression sleeves reduces the incidence of arm swelling in the first year following breast cancer surgery. We conducted a single-blinded, parallel group randomized controlled trial at the Tata Memorial Cancer Center, Mumbai, India, from 2017 to 2020. Ethics clearance was obtained from the Institutional Ethics Board. The trial was registered prospectively in the Clinical Trial Registry of India. We screened nearly 900 women for eligibility before surgery. We included women if they met the following criteria. Women 18 years of age or older, posted for breast cancer surgery, without arm swelling at baseline, and able to read, write in English, Hindi, Marathi, or Bengali, and able to wear compression sleeves independently. After the surgery, we screened their lymph node excision status. If they underwent axillary lymph node dissection, we retained them in the trial. 307 women who underwent axillary lymph node dissection enrolled in this trial. So we collected the participants' demographics and medical history and performed the physical examination, bioimpedance spectroscopy assessment, and arm circumference measurement using established protocols before surgery. Additionally, participants filled out the quality of life questionnaire, the EORTC QLQ-C30, and BR23 questionnaires. We stratified the participants based on the body mass index and pre-operative taxane-based chemotherapy status. Subsequently, a person who was not in the research team allocated them into compression and control groups using computer-generated random numbers placed in sequentially numbered opaque envelopes. All participants attended a group therapy session on the first postoperative day. During this group therapy session, they received exercise, arm, skin, and drain care instructions. The compression group received a pair of Sigvaris advanced arm sleeve with 20 to 25 millimeter mercury compression pressure. So we instructed the participants in the compression group to wear the compression sleeve for more than 8 hours a day from the first postoperative day until 3 months after their chemotherapy and radiotherapy completion. Participants maintained a diary to note their compliance for the compression therapy. We reassessed the participants on the day of suture removal the 6-month and 1 year following surgery. We also trained the participants' family members to take arm circumference measures and to record lymphedema-related symptoms and pitting. They sent these data electronically every month, which was screened for any signs and symptoms of arm swelling regularly. We encourage participants to approach the research team if they noticed any lymphedema-related symptoms for further evaluation. So the primary outcome of this trial was the incidence of arm swelling determined by impedance ratio based on the normative threshold. An interarm impedance ratio of more than or equal to 2 standard deviation above the normative mean was considered arm swelling and referred to lymphedema therapists for further evaluation and management. This trial had 2 secondary outcomes. One of the secondary outcomes was the incidence of arm swelling determined from arm circumferences. We used relative arm volume increase from baseline more than or equal to 10% as a threshold. The other secondary outcome was the documentation of first minimally important difference in the general health, physical functioning, breast symptoms, and arm symptoms domains of the EORTC QLQ-C30 and DR23 questionnaires. Though there are many other domains, these domains we thought is relevant to the arm swelling. So 3 participants from each group did not come for follow-up assessment after the baseline assessment, so they were dropped from the analysis. Thus, we included 152 women from compression group and 149 women from the control group in the final analysis. We reported the descriptive statistics of patients and treatment-related characteristics. We analyzed the primary and secondary outcomes using the time to event analysis known as survival analysis. We used survival analysis since many participants were assessed between protocol specified follow-up visits for arm swelling compliance. So let's move on to the results. This table shows the participants and treatment related characteristics. As you can see, participants in both groups were well balanced in all the characteristics, particularly the high risk factors such as body mass index and the type of surgery and the extent of nodal resection. So this slide shows the survival analysis results based on the interarm BIS ratio threshold. For those who are not familiar with survival analysis or time to event analysis, this graph is known as the Kaplan-Meier curve. The time since the surgery is plotted on the x-axis, and the proportion of the women free from arm swelling is plotted on the y-axis. In the event of arm swelling in the study group, any of the study group, compression or control group, the arm swelling free probability drops. And as you can see, the arm swelling free probability dropped drastically at the beginning of the study in the control group compared to the compression group. The difference was maintained during the 1-year follow-up. This indicates that the arm swelling rate was higher in the control group than in the compression group, which is also was evident in the log rank test, and there was 10% reduction in the compression group. We also did Cox regression analysis, which showed the hazard ratio of 0.61. And for those who are not familiar with Cox regression analysis, the hazard ratio of 1 means there is no difference between the groups, that is the compression and control group, whereas less than 1 means there was less incidence of arm swelling in the compression group compared to control group. So again, when we repeated the analysis using the relative arm volume based threshold, that is relative arm volume increase of more than or equal to 10% from baseline, It confirmed the findings based on the bioimpedance-based threshold that we have seen in the previous slide. Again, you can see both the groups' difference was maintained throughout the whole 1 year. So the 12-month event rate in the compression group was 10% lower in the compression group than in the control group. The main difference between this slide and the previous one is that the overall 12-month event rate is considerably lower when we used the relative arm volume increase based threshold. This is, of course, expected since the relative arm volume increase is a more conservative threshold than the bioimpedance spectroscopy-based threshold. So this table shows the time to event analysis of quality of life subscales. Surprisingly, the time to event analysis of quality of subscales was comparable between both the groups, and you can see the ratio here. And so the early use of compression sleeve in hot, humid condition in India did not negatively affect the overall quality of life. So to summarize, the prophylactic use of compression sleeves reduced the incidence of arm swelling, delayed the occurrence of arm swelling, and it did not negatively affect the quality of life. So the strengths of this randomized control trial were that it was adequately powered, used concealed allocation, and we have seen that groups were comparable at baseline. Longer follow-up will add value in terms of persistent lymphedema. And this trial was published in the Journal of Clinical Oncology, as Professor Szuba said in the beginning. So for clinical consideration, some women developed arm swelling even with prophylactic compression sleeve. Therefore, it is paramount to educate women about the lymphedema symptoms, arm measurements, and pinching and pitting tests so they can self-identify arm swelling early and seek help. This combined approach will reduce the burden on the healthcare system. I profusely thank Sigvaris for providing compression sleeves used in this trial as a grant. However, Sigvaris had no input into the study's design, execution, or reporting. I also would like to thank the entire team worked to complete this trial successfully. Thank you. And is there any questions? Then I would like to answer.
Pinar, would you like to comment on this? Professor Borman?
Well, actually, I would like to ask that what kind of pressure garment did the patients get? Flat knit or circular knit? And another question I wonder is, they have measured the circumferential measurements they have performed, but I think the volume, did you perform the volume? Maybe I have missed it. The volume measurements?
Yeah, I would like to take the first question first. And about the compression sleeves, we used over-the-counter advanced sleeve from Sigvaris. So it was a circular knit. It was not a flat knit garment, as this was used for prophylactic purpose, and none of them had edema in the beginning. And for about your second question, we calculated the volume based on the circumference measures. We didn't do any volumetric measurement using immersion method.
I see. But it's a very important study that adds value to the literature, because when I'm preparing these presentations, I have read all the literature for the prevention of breast cancer-related lymphedema, and it's the compression garments are the neglected part of the prevention, because there are not so many studies like the studies with exercises or other other skin care and other educational strategies. But in my opinion, one of the most important aspects of prevention is the compression garment. But not all of the patients. I will emphasize in my presentation, the patients at risk should be considered, I think, for cost effectiveness and for not bother other patients with psychologically not afraid of them for the risks. I believe.
Okay,
Thank you.
for that.
We have raised, I see raised hand from Nouf. So do you have any questions? Comments?
Yes, a very interesting study, Dr. Vincent. I'm wondering about patient compliance with wearing the garment. And the second question is about weight change. Is there any monitoring to the weight change of the patient during the period of the year? And have you changed their pressure garment throughout the year? Because this is one of the things that we have struggled with. We have tried a few years back to give pressure garments as a preventative measure. It was not a study, it was just an initiative. And we faced some problems with the follow-up of patients and the compliance in wearing the garment, especially they know that this is a preventative and not curative or a treatment for them.
So I would like to answer the first question about the compliance. And yes, of course, in this presentation, I have not presented the compliance data. However, they have used the compression sleeves regularly, and since we have got most of the compression sleeve group patients had come back for the replacement since the compression sleeves had worn out, and in some cases it worn out around 4 to 5 months, and some of them wore it for longer period of time since their post operative chemo radiotherapy was longer, so they had to use for a longer time. So we had to replace. So in our population where this study was conducted, because many patients had edema and they see regularly with patients having bandages, they were so much afraid of arm swelling, and they were more interested in prevention. That's why if you had seen the flow chart, though we approached 900 women, screened 900 women, only 5 of them refused to participate. And out of that 5, few asked for, if I get into the study, what is the guarantee I will get compression sleeve or I will be randomized to compression sleeve? So they were more interested in wearing sleeve to prevent edema. So yeah, I hope that answered your question. And I would like to, at least present this compliance data as early as possible.
And I see raised hand from Orsi.
Thank you. So patient compliance was also one of my questions. So you just answered that. My other question was, you mentioned at the end of your presentation that a long-term follow-up is required. Is this something that you're planning on doing? And if so, what does that mean? How long is the long-term?
Yeah, so we are following them for 5 years. So the team back in India is doing that. And once that data is completed, then we will be able to really see how many of them had effect on preventing the chronic edema. So yes, that would be really interesting. Yeah, we need to wait. But yeah.
And Margaret McNeely, you.
Yeah, very, very interesting work and great study. I'm just wondering, did you have a look at whether there was a difference between the women who received taxane-based chemotherapy versus non-taxane based?
So we haven't done that analysis, and we stratified for pre-op taxane, though it is not shown to be a high risk yet. But for post-operative taxane-based chemo, we didn't do any analysis. So that's a good thing to look at it.
Okay. And my other question for you was, did you, you had for your circumference measures, you used the cutoff of 10%, but did you notice that there were some women presenting perhaps that had less than 10% that you might have, diagnosed versus through your bioimpedance?
Post analysis, we also run through 3 standard deviation for bioimpedance as well as 5% Ravi, and even 5% Ravi as well as 3 standard deviation bioimpedance spectroscopy showed the same difference between compression group and the control group. That is 10% less women had arm swelling.
Okay, thank you. We have some questions from our listeners. And may I read? Do you see them?
Yes.
Will you try to?
Yeah. So, greetings. Would it be possible to highlight again what were the outcome measures you were monitoring to identify an increase of incidence of lymphedema? Were you relying on bioimpedance or arm measurements? So the primary outcome was bioimpedance spectroscopy. So to refer patients to a lymphedema therapist, we used the bioimpedance as the baseline, and we also analyzed using the circumference measure. So that both the measures we did. And next question: how long should use arm sleeve for post-mastectomy patient? Although we don't have any current evidence to suggest that how long the patients need to use arm sleeves post-surgery, we came up with a physiological reasoning that if there is an inflammatory changes, that was the reason for edema or arm swelling. So we wanted to support the lymphatic system at least 3 months following any adjuvant treatment or surgery. So if the patient received only surgery and there was no postoperative chemo or radiotherapy, they used the compression sleeve only for 3 months. And if they had, for example, 6 months of post-chemo radiotherapy, then they used the compression sleeve from day 1 till 6 months, and beyond that 3 more months to support the lymphatic system. So every woman in this study had different compression sleeve usage. Duration was different between patients. And so that's how we managed this group of patients. So we wanted to see the short-term use of compression sleeve effect on the prevention. And next question. My question regarding the biomarkers like blood, lab test, or any had been performed or planned. So in the initial protocol, we planned for inflammatory biomarkers. However, it was way too much to run as a PhD study because I didn't have that much funding to run biomarkers. So we didn't do that. And most of this women's samples are stored. However, it may need another study. We need to get ethics clearance to look at the biomarkers, but we didn't do any biomarkers as part of this study. So another question is, how did you measure the compliance? In other words, how can you be sure they were wearing it? And partly I answered this question. And the first part of your question is, how did you measure compliance? So we provided each compression sleeve participant or the participants in the compression group a diary. And in that diary, they had to record whether they wore the compression sleeve 8 hours or more than 8 hours, and they have to record how many hours. And if they have recorded less than 8 hours, what was the reason for not using compression sleeve for 8 hours? It could be related to some medical issue or any other issue. So we wanted that information. So this data we had to analyze, and we will be able to then answer your second part of the question. Thanks. I hope I have answered all the questions in the chat.
Thank you so much, Vincent, for the answering and also for the presentation. We have prepared 2 poll questions based on your presentation. Maybe we can just show them quickly. Okay, the first one is about women. How long did the women wear the compression sleeve in the study? I think it was not mentioned in the presentation, so this will be a guess from the attendees. Just guess how much time the women were wearing the compression sleeves. Okay. Most of the attendees think that they wear it more than 8 hours a day at the first postoperative day until 3 months, and this is also the right question. So I'm very impressed. What do you have any comment on that, Vincent?
Yeah, I think most of them got this answer correct, and I'm impressed. They were very attentive.
Great. Then we have the second one, maybe, Khaled. So the second one is about the prophylactic use of compression sleeve. What was the main effect of the compression sleeve following axillary lymph node dissections? There's one choice also there. Okay, also here, very impressive. The second one was the right answer to it. So very good listening to the presentation. Any comments from your side also to the second answers?
Yeah, so I'm again impressed with their answers, and yeah, so I tried to trick them, but yeah, they got it right. Yeah, thanks.
Great, fantastic. With this, I think I can hand over to Andrzej once again for the second part of the presentations.
Okay, thank you. And so it is my pleasure to introduce Professor Pinar Borman. Pinar is Professor of Physical Medicine and Rehabilitation and Angiology in Ankara City Hospital Rehabilitation Center in Ankara. Professor Pinar Borman graduated from Ankara University Medical Faculty and received her PMR specialty from Hacettepe University Medical Faculty Department of Physical Medicine and Rehabilitation. She has been associate professor in 2003 and professor in 2012. She has received her PhD in 2011 on angiology and became an angiologist. Dr. Borman has been certified from Norton School of Lymphatic Therapy in 2013 and became a lymphedema specialist. She is also going training in kinesiotaping in the US, and she is certified kinesiotaping practitioner. Professor Borman is the founder member and chair of Turkish Lymphedema Association. She has also formed Hacettepe University Lymphedema Research and Practice Center and was head of this organization until 2020. Professor Borman is the representative of Turkey in the International Lymphedema Framework, International Board, and founder member of International Lymphedema Association. She is a member of International Lymphedema Framework, European Society of Lymphology, World Institute of Pain, International Association for the Study of Pain, International Society of PMR, and several national organizations. Okay, she is, just to shorten this a little bit because she is well known, she is the author of the more than 200 international and national papers and more than 250 oral and poster presentations in her area and has been cited more than 2,000 times in the last 10 years. Professor Pinar, the floor is yours, as we say.
It's okay. Okay, thank you very much for the nice introduction. I'm so happy to be together in this seminar, MOH seminar, with these distinguished speakers and moderators. I would like to thank you to the organizers and also the Sigvaris family. My topic is the importance of prevention of lymphedema in breast cancer-related lymphedema, how and when. Breast cancer is the most common cancer and the leading cause of cancer death among women worldwide. Improvements in diagnosis and treatment reduced the mortality rate in recent years, but as more women survive from breast cancer, the number of women affected by long-term side effects like lymphedema is increasing. Breast cancer-related lymphedema is a serious and concerning condition that can occur after breast cancer surgery, lymph node excision, and/or radiation therapy. A great number of breast cancer survivors reported to develop lymphedema according to different country data. Lymphedema is established within the first year generally, and the peak incidence is 18 months after surgery for axillary lymph node dissection. But although these frequent numbers, the awareness and care of condition is still being neglected by healthcare professionals. Lymphedema is still a major healthcare problem in both developed and non-developed countries. If left untreated, functional disabilities, psychosocial problems, and impaired quality of life can be seen in patients with this condition. It is associated with a substantial increase in healthcare costs. Previous studies indicated that the costs related to prevention and early diagnosis programs are lower than those of treating lymphedema. Therefore, prevention strategies seems to be essential. The importance of understanding the risks of lymphedema after treatment is widely recognized, but patients frequently do not receive basic information about these risks. As a result, many patients are unaware of the risk factors and prevention strategies. Here you can see the risk factors for breast cancer-related lymphedema. The most important ones are type of axillary surgery, in which axillary lymph node dissection is 4 times higher risk for lymphedema, the removal of more than 5 lymph nodes, radiation therapy, and to be overweight and obese. But in addition to these risk factors, we can count that chemotherapy, especially taxane-based chemotherapy, infection or injury, presence of metastatic lymph nodes, advanced stage of the breast cancer, not participating in regular physical activity, decreased range of motion of the shoulder, or older age may also be the risk factors for these patients. The prevention of breast cancer-related lymphedema can be classified in 3 groups. Primary prevention of this condition relates to avoiding injury in the lymphatic system to a level whereby risk of breast cancer-related lymphedema increases. For example, during the operation, sentinel lymph node biopsy instead of ALDN, axillary reverse mapping, lymphoprocedure like lymphovascular anastomosis, or modified radiation techniques can be counted among primary prevention strategies. But today's topic is secondary prevention, which relates to prospective monitoring of patients at risk for the purpose of early identification of lymphedema, with or without modification of other potential factors that could ultimately protect or support lymphatic function. Tertiary prevention relates to implementing strategies that may reduce the impact, prevent progression or management of breast cancer-related lymphedema after it has developed. So when should the prevention of breast cancer-related lymphedema begin? Actually, the ideal way is to begin the prevention before the breast cancer treatment. The patients can be educated about risk factors and prevention strategies before the surgery or before the treatments. But we generally perform prevention strategies after the breast cancer treatment. Prospective surveillance approach for monitoring lymphedema can be done for these purposes. According to risk factors, the prevention strategies should be applied after the surgery and/or other treatments. Many patients report lymphedema symptoms without an obvious arm excess volume or arm edema. Therefore, early detection and identification are important. With early start of treatment, duration and progression of lymphedema can be limited, as shown in many of the previous studies. Clinical lymphedema is defined as a 2 cm increase in limb circumference, 200 milliliter increase in limb volume, 5 to 10% volume excess compared to unaffected arm. There are 4 stages of lymphedema. Stage 0 indicates subclinical, no visible change. In this stage, patients report vague heaviness. In stage 1, mild soft edema is present and it subsides with limb elevation. These 2 stages are very important for early diagnosis and prevention, but patients' subjective symptoms can vary depending on timing, temperature, or activities of patients. Therefore, they may not be reliable. So, lymphedema surveillance becomes very important and needed in this approach. For surveillance, an initial preoperative measurement should be obtained, followed by regularly scheduled postoperative measurements every 3 months for the first 2 years, then every 6 months for 3 to 5 years, which are suggested by previous studies. These periods consist of monitoring lymph volume and patient subjective complaints in order to define subclinical lymphedema. Several methods are used to detect and monitor early lymphedema, but there is no consensus concerning the best measuring tool. Objective measures of early breast cancer-related lymphedema include circumferential measurements, water displacement method, bioelectrical spectroscopy, and perometer. In addition to these methods, diagnostic imaging techniques are promising and may also be used. In circumferential volume method, each arm is measured from the wrist to axilla by 4 centimeters. Lymph volumes and excess lymph volumes are routinely undertaken using a simplified truncated cone formula according to geometric approximation as seen here at the bottom. Greater than 3% increase in volume indicates subclinical lymphedema in this method. There are advantages and disadvantages of this procedure. This method is easily accessible and affordable, but the measured values of are approximate for multiple reasons, like the perpendicularity of the tape and the pressure applied by the therapist. Also, the measurements may not be taken each time exactly from the same place. Therefore, this measurement may not be reproducible and reliable. There are practical innovations in this area. PeriKit is one of them, which is an accurate, reliable, and fast solution to measure the extremities, in which we can standardize measurements worldwide. It's affordable, adjustable to all limb lengths, and combines the advantages of digital, empirical, and traditional measuring devices, which reduces measurement errors to a minimum. And the effectiveness of PeriKit is based on several scientific studies that are conducted recently. In water displacement method, each arm is placed into a large cylinder of water, as you can see here, and the water that's pushed out is measured and compared to the unaffected side. It's an accurate and inexpensive, and maybe according to some authors, a gold standard method for the volume measurement. But it's time-consuming, unhygienic, and requires strict protocol. Excess volume greater than 100 or 150 milliliter indicates subclinical lymphedema in this method. Bioelectrical impedance spectroscopy determines the quantity of extracellular fluid by measuring tissue resistance to the flow of an electric current. It's simple to use and non-invasive, and according to previous studies, periodic monitoring with BIS reduced the incidence of breast cancer-related lymphedema. In this method, the LDEX value of greater than 6.5 is considered subclinical lymphedema, as seen in the literature at the below, and values greater than 7 are considered as clinical lymphedema. Perometer is a quick, accurate, reproducible way of measuring volume, which utilizes a frame of infrared light beam receiver to measure lymph outline with sub-centimeter definition and thus derive lymph volume by the disk model method. But it's costly, and in this method, greater than 5% difference means subclinical lymphedema. In addition to these techniques, imaging modalities are also promising. Near-infrared fluorescent imaging, lymphofluoroscopy, ultrasonography, or maybe lymphoscintigraphy. It's not so pronounced in this early identification, but we are awaiting for the results of some study protocols that appeared in the literature to determine their value in early diagnosis in the future. So how shall we prevent the breast cancer-related lymphedema? Under this topic, we can say that awareness, education, information, skin care, compression garments, exercise, weight control, and minimizing stress are the most important points in the prevention of this condition. Awareness and education are needed both for health professionals and patients, because early detection of symptoms by health professionals is very important. Also, recognition of early symptoms like heaviness or perception of swelling by the patients should be considered. Patients should be well informed and be aware about their risk for breast cancer-related lymphedema and should be informed about the preventive actions. Therefore, monitoring and providing a preventive self-management program is very important. Self-management program for prevention includes skin care, in the early phase drain care, exercises, compression garments, and recognizing symptoms and contact health professionals in early periods. In skin care, patients should avoid repeated punctures and injuries, keep meticulous skin and nail care, avoid tight-fitted clothing or jewelry. And they should use insect repellents, wear gloves, and all these things we always emphasize to our patients are and well-known precautions for preventing lymphedema. Weight control is very important, which is commonly neglected among this population, because being overweight or obese are risk factors for breast cancer-related lymphedema. There is no specific diet, but healthy diets are suggested, and weight reduction to reach to ideal weight is needed in the prevention. Active exercises are one of the main components of lymphedema prevention programs. Exercising the lymph at risk activates musculoskeletal pumping and increases venous and lymphatic flow. Upper body exercises can also restore the sympathetic impulse to the lymphatic vessels and help in long-term management of lymphedema. The optimal time to start exercising after surgery is not clear, but suggested to begin before the surgery. Aerobic exercises as well as resistance training are beneficial for physical endurance and strength. For example, 150 minutes aerobic exercise and 2 sessions of resistance training per week may be needed for the prevention. Exercises can be classified in 3 groups, as you have seen here. The first, in the first stage, which is done post-operative the first days, we generally prescribe deep breathing, ball squeezing, hand opening and closing exercises before the surgery and within 24 hours after surgery. In the second stage, aerobic exercises, for example, walking about 20 minutes, in addition to the first stage exercises, can be done following the removal of the drains, which means in the second week after the surgery. In the following stage, which means the post-operative week and afterwards, stretching exercises are recommended for the patients for prevention. Compression garments. The prophylactic use of compression garments to prevent lymphedema has received relatively little attention, but all patients who are at risk for breast cancer-related lymphedema should prescribe a compression garment. CCL1 to 2 pressures about 18 to 21 in flat knit, or in circular knit 30 millimeter HG are enough for prevention, and also these low pressures increase the compliance. Which type should we choose? The sleeves from wrist or from metacarpophalangeal joint, and the circular knit pressure garments can be chosen for prevention. The suggestion for the time duration of wearing is about 8 hours a day for the prevention. Randomized controlled trials indicated the effectiveness of compression sleeves following breast cancer, especially in the first 3 months up to 12 months. Neither exercise nor education alone decreased the incidence of breast cancer-related lymphedema in some studies, but use of compression garment was associated with decreased incidence and prevention of lymphedema in most of these studies, as you have seen at the bottom. Literature reviews indicated the effectiveness of lymphedema prevention programs with compression garments, in addition to general precautions. Prophylactic compression sleeves not only prevented the lymphedema, but also increased functionality and quality of life among these patients. The adherence of patients to compression garments was most important aspect of prevention. Therefore, education and follow-ups are very important. In studies, the incidence of breast cancer-related lymphedema was shown to be significantly lower in patients who adhered to daily use of compression garments, especially in the first 3 months during 2 years surveillance programs. As a conclusion, breast cancer-related lymphedema is a serious and concerning complication after treatment of breast cancer, leading to functional disability, limiting daily living activities, and impairing quality of life. Patients should be well informed and be aware about their risk for breast cancer-related lymphedema. Surveillance, offering early intervention and prevention to these patients who are at risk is feasible. Prophylactic intervention and self-management techniques that may help to prevent and reduce breast cancer-related lymphedema. In addition to education, skincare, and exercises, pressure garments are useful and effective in prevention of breast cancer-related lymphedema, as shown in majority of the studies. As patient adherence play an important role in preventing this lymphedema, long-term follow-up is important and should be considered in this patient group. I thank you for your attention.
Thank you, Pinar, for a great presentation, as usual. And I think, Sylvain, we have now time for poll questions, according to the agenda.
We can just look at the poll questions first and then go into the questions and answers as they are coming in now.
Sure.
Okay, the first one was about which of the following is not a preventive method for breast cancer-related lymphedema. There is one choice. Okay, very good. The second answer is the right one. 74% of the attendees found the right answer. Great. Any comment from you, Pinar, to this result?
Yeah, it's great. I think I have the audience listened it very carefully. Actually, as I have shown in my slides, the prevention strategies include exercises, skin care, education, and compression garments. But pneumatic compression pumps is not used actually in our practice for prevention, and it's not suggested. Neither in prevention nor in the treatment we use it in the upper extremity lymphedema, but there are some echoes that use it in addition to other treatment methods. But the answer is yes, the pneumatic compression pumps is not effective or is not used in prevention strategies.
Okay, great. We have a second one, Colette. There the question is about which of the following statements is not true. Also one single choice here. Okay, here we have slight less correct answers. So the majority was looking for answer A. The right answer was the answer D. Compression sleeve in addition to skincare exercises reduce volume in breast cancer related lymphedema. Any comments here, Pinar?
Yeah, maybe they have misunderstood the question. Is not, was asked. Actually, pressure garments do not reduce the lymphedema, breast cancer-related lymphedema. They are used to protect the effectiveness of the first phase of complete decongestive therapy, and they are used in the maintenance phase. They can prevent, in addition to exercises, skin care, and educations, prevent the breast cancer-related lymphedema, but does not reduce the volume in the breast cancer-related lymphedema, which is apparent, which has began and not prevention, began and do not reduce it. Just keep the success of the first phase of CDT.
Okay. I see that there are some questions also from the audience. Can you see them also? Do you want to read them by yourself?
Okay. I'm opening it. Yeah. Apart from compression garment, do you think low laser therapy targeting the lymph node and the fibrotic area is effective in managing upper limb lymphedema? Yes, we are talking today about the prevention, but I will answer this question because we generally use, I will answer this question as yes. We also use low laser therapy for the fibrotic areas in the CDT phase 1 active treatment phase in the management of upper limb lymphedema, but it is not used as a preventive method. I would like to emphasize. And the second question is, what an excellent and clear presentation. Thank you. Do you have specific take-home message to your patient concerning the self-management? Yes, I can talk about it in two aspects. One is for prevention. Actually, in our hospital, we generally would like to see the patient just after, before the surgery or just after the surgery. And we have nurses, educated nurses for general surgery department that give education for the patients who will going to have breast cancer surgery and or other therapies. And we give them brochures to educate and to inform them about the risk factors for lymphedema or to the risk factors for their shoulder range of motion restrictions. And prevention, in the prevention methods, we generally tell them about the first signs of the lymphedema. For example, if you have heaviness in your arm, if your clothes are short to your body or does not fit you, you should submit to the Department of Physical Medicine and Rehabilitation outpatient polyclinics. We have a lymphedema outpatient polyclinic in our hospital, and we call them, we invite them to submit this unit. But in the self-management period that is taken after the CDT period, we educate all our patients in the active phase of CDT. In our lymphedema unit, every patient getting CDT are educated, or their caregivers are educated for self-bandaging, for self-exercises, and for self-MLD. Drainage methods. And the most important part of the maintenance treatment is the self-management, which is as longer as the patient lives. Therefore, in self-management methods, I advise my patients, when you get up from the bed, first you will do your self-drainage techniques, and then you will wear your compression garments. Under compression garments, you will perform your lymphedema exercises, and then you have to walk at least 20 minutes a day or at least 3 days a week for your self-management. This is very important. And we also advise them to bandage themselves, to self-bandage, or their caregivers can bandage them at least 3 nights a week in the maintenance phase. And we always tell them to lose their weight if they are obese, or to control their weight in an ideal as an ideal weight for their BMI. And these are the most important points for self-management. I think these are any question, general presentation. Thank you. There are 3 questions I have seen here.
Third one is just thanking for the presentation.
Yeah,
I don't know if the expert panel has some questions also for the presentation of Pinar.
Yes, a wonderful presentation as usual from Pinar. Now, I want Pinar, I want your comment on such a thing. We know that compression garments are good for prevention, but we also know that about 50% of high-risk patients after breast cancer surgery will not develop lymphedema ever. So they don't need this garment at all. So personally, I like the prospective surveillance model from Nicole Stout. And so what do you think about this? And I think that's something that I recommend here in Poland. What do you think?
Yeah, thank you. Actually, you are right. The patients who are at risk for lymphedema may not have lymphedema in the progressing time, but we cannot take this risk for our patients. Therefore, because if we think that they will not, or if we assume that they will not develop lymphedema, we will not teach them. We will teach them the risk factors and educate them, but we will not prescribe them compression garments. But what about if they get it? The cost effectiveness we should think about. the treatments are costly. I don't know which country has reimbursements about this, but when you take into the consideration the quality of life of the patient, the functionality of the patient, and the budget of your country, I think, in my opinion, it's logical to prescribe them low-level compression garments, especially the circular knit and ready-made ones, which are not as expensive as the other ones. In my practice, if they have the risk factors, especially axillary lymph node dissection, radiation therapy, obese patients, and I consider them, they are at risk. And in addition to the education, exercises, and skincare and other things, I generally commonly prescribe them compression garments. But I wonder the comments of other experts in this area. Maybe this can change according to the country's reimbursements or country's budgets. But in my practice, you are right, they may not develop, but I cannot take it account as a risk.
Okay, well, thank you for your answer. The PSM model is well validated also for cost effectiveness. So it is, I think, in any case. Well, simply what they do, it's 3 months after the surgery, they measure for bioimpedance of volume. Any slow increase in volume, it puts the if there's any even small increase in BIC measurements or BIS measurements or volume, they put round knitted garment on those women. So this is actually, and it goes every 3 months for the first year and further. So it is a very nice project, and actually it was validated in many countries already, and I think it's a good approach, and I like it.
Yeah. Yeah, and surveillance programs are very important. We have also published a paper about this. We measured the breast cancer patients after the surgery, 3 months and 6 months, but it was a COVID period and we could not complete the study up to 1 year, but it was published. And we have used LDEX, bioelectrical impedance spectroscopy in this surveillance period. It was very useful. Yes, the ratio was not so low that we have expected. And according to your suggestions, I agree with them. If there is a very little change, even not only in the BIS, because BIS may not be present in every center, but circumferential measures, according to circumferential measures, it's very easy to get the volume. So when the volume change is greater than 3%, if the patient has one-sided breast cancer surgery, we, in my opinion, we can begin to prescribe compression garments. We can prescribe it. We should do it, I think, because there are generally housewives in our country working hard. They're doing houseworks and using their arms, and there is another risk for their daily living activities. But it may change according to countries, according to profiles of the patients. But in our country, many of them, majority of them are housewives, and we should be cautious about the risk of lymphedema in a very little increase, even in a very little increase in circumferential measures.
Thank you so much for a great presentation. This may be a very broad question and maybe directed to some of the other panelists as well. We know that translating research into clinical guidelines and then into the real world environment happens incrementally. When it comes to something like prescribing compression to women as a preventative measure, what kind of barriers have you guys all observed? Because I can think of lots of barriers that exist, from psychosocial to financial to lots of other things. So that's something I would be really curious about.
Yeah, there are lots of barriers in prescribing them. First of all is the reimbursements. In our country, reimbursement part is very low, about 1/3 of the pressure garments. And the second one is the compliance to the garments. And in our unit, we have a very wide range of follow-up strategies, and we phone them, we call them, and if we follow up closely, we can see their compliance and modify them and activate them to use it. But there are very hot parts of Turkey, as same in other countries. The weather changes. The appearance of the garments are a problem for the women, because I have many patients that telling me that everybody is asking me the thing on my arm, what is it for? Why are you wearing? And it psychologically affects the patients. But sometimes it's easy, the way of living also, because when they wear the compression garments, they may not have so many restrictions as told before. You will not use your arm. You will not do your housework. You have to take it like this in an upper way. These are actually not true. And when the patient wears the compression garments, I say my patients that they are free. They can do everything they want in their daily living activities, and especially in working with their hands in laptops and other things. Workers and other officers generally need these pressure garments because they protect it from the risk of lymphedema. But not all patients. The patients are at risk. If they are at risk of developing lymphedema, in my opinion, in my practice, I generally recommend them to wear compression garments for the prevention.
Thank you.
Okay, so maybe now I'm not sure who was the first, but maybe Nouf, a question.
Thank you, Professor Pinar. Very nice presentation. The issue of awareness and education has been always very important to this subject. My question is, how much education are you looking for in order to avoid putting patients in too much pressure on lymphedema? Because with the available information online, a lot of my patients are extremely reading the details of problems with lymphedema and developing lymphedema, which is putting them into stress as well. So what do you think about that?
Yeah, actually, the most important part is the skincare, I think, because meticulous skincare is very important in order to inhibit the infections and other things. And for skincare exercises, I always tell them not only the hand or arm exercises, but also aerobic exercises, which also develops their psychosocial status. In the skincare, venipunctures and taking blood pressure from the affected arm are not true anymore, as shown in previous studies in the literature. So we should be cautious about not to make a fear among these patients about the precautions. But if she's a housewife, she should wear the gloves when working in the kitchen or working in the garden. The bites, animal bites are very important. Mosquito bites especially. I have lots of patients that have mosquito bite and acute lymphedema, or lymphedema patients with mosquito bites get cellulitis because of this. So these precautions are very important. Exercise is another part that from the first visit, I tell all my patients that about the lymphedema exercises, very easy ones, like collecting apples from the tree, like swimming, I tell them. The very simple ones, and breathing exercises. Diaphragmatic breathing is very important. And of course, weight control is very important. They should lose weight. We work with the dietitians together, and some of them are depressive, have depression, and we work with psychologists in our unit. We work actually multidisciplinary, and according to the patient's comorbid conditions, we modify these precautions and education to these factors.
Margaret?
A wonderful presentation. Thank you. I have one question for you. You mentioned about using the circular knit garments in the case of prevention. Can you speak to when you may consider switching a patient to perhaps a flat knit garment, or selecting a flat knit over a circular knit?
Yeah, of course, not in all patients we prescribe the circular ones. We generally choose the flat knitted ones in patients who has not homogeneous, who has not normal shape of the arm. For example, it can be a long arm. We are talking about the prevention. The arm is not swelled. It's just looking like a normal arm, but it can be short or it can be long. That may not fit with the ready one ready one sleeves. In these conditions, we generally prescribe them the flat knit ones. But otherwise, we generally suggest them to use the circular knit ones, because they are cheap, they are ready-made, and they can use it very easily, because also we prescribe the pressure CCL1 in these compression garments for the prevention.
Vincent, do you have questions?
Yeah. So this is about some comments on prospective surveillance. So as Professor Szuba suggested, the prospective surveillance model is been there around for some time, and it has been published quite extensively in many publications. And however, there are some practical difficulties in few countries. For example, if we consider prospective surveillance and payment for each of those visits, and compare it to the compression sleeves, the second one becomes much cheaper in certain scenarios. And also, many countries with people coming from 2,000 kilometers from 2,000 kilometers away from this main center. For example, in India, Tata Memorial Hospital serves to patients or operates patients, those who are traveling 1,000 and 2,000 kilometers away from. And following them up prospectively just for lymphedema is quite impractical. And So in such cases, probably compression sleeves and self-monitoring is much important. Teaching them how to screen themselves using either circumference measure or pinching and pitting test, probably much helpful. And if they identify some symptom, then probably they can approach for the specialist intervention, assessment and intervention. So also another study, a large study by Buntred, done in UK, they, even though it was done in a developed nation, and he also complained of people not attending for prospective BIS measurement, and and they come back with developed swelling. So that is another issue with patients not following up for prospective assessment.
Well, thank you. It's a very good comment. Of course, you are right. If there's no practical possibility to do it, to do prospective surveillance, the choosing the sleeve options is much better. I agree totally.
Yeah.
Thank you. Well, we have one question, I think, from question and answer corner. Can you see this, Pinar?
Yeah, I see it. I have seen it. As a patient and a lymphedema therapist, I would recommend a black or a sleeve rather than a flash-colored sleeve. The former triggers comments, what's wrong with your arm, but a black sleeve does not. I also encourage dragon boating. I myself paddle with a BACS team, and the benefits of dragon boat racing are well documented. Well, thank you for these suggestions and comments. She's also a patient, and these recommendations are very valuable. Yes, the color of the sleeve is very important, and we have also in our area colorful sleeves, especially the children like them, and also the some women, working women, are very satisfied with this color for sleeves. Thank you for this recommendation.
Okay, thank you.
Yeah, there are some sleeves with even designs. Like they are very beautiful. And one more comment, if I may. When we used the advanced Sigvaris sleeve, we, usually we used to face challenges with a different shape and size arm, and the sleeves which we had usually difficulty in fitting with different size. For example, women with a broad shoulder or broad upper arm and narrow wrist. But with advanced sleeve, we had multiple options to choose from, because varieties of shoulder or upper arm size, varieties of wrist size. So during the trial, which was very helpful, and we didn't specifically ask for advanced arm sleeves, though we got from Sigvaris the advanced arm sleeve, and which was very helpful. I'm not promoting Sigvaris in any way, but the advanced arm sleeve definitely gave us more choices to choose from.
Yeah, you are right, and especially in obese patients, we cannot use the ready-made ones, and with the shapes very different in the upper and lower parts, they may be very useful. Yes, I agree with you. Thank you.
That's right. I think we have some time for more discussion and comments, and I think, well, that whole meeting was wonderful. Both presentations were great, and our discussion, I feel it was very nice for listeners. I don't know if anybody wants to comment on the meeting.
I have just a quick question also for Pinar from my side, because you mentioned in your presentation that you are bandaging the patients 3 times per week for the night also. What is your experience regarding the comfort of this? Because I'm asking because we have Margaret here that did just recently present the study where they have used adjustable compression garment, night garment, in addition to the normal therapy, and this was quite impressive that they could even achieve better results just by adding also these more comfortable compression systems in the night.
Yeah, you are right. I mean, bandaging is not a multi-layer bandaging actually, because the patients generally may not be compliant to wear their pressure garments, or they may gain weight, or they may not perform the self-management techniques that they should do in the maintenance period. So their arm can be swollen in different terms, in different times, and we generally advise them to make night garments. We always not always use this multi-layer bandages, but we prescribe them the adaptive velcro devices, night garments. They're also very useful according to the patient's situation, but we are very satisfied with the velcro adaptive ones. I would like to emphasize it because they can not only be used in the night as a night bandaging, but also in the active CDT phase instead of multi-layer short stretch bandages. We have performed a study and published last year, and we indicated that they can be used in both phases of CDT, and they are very comfortable, and the patients are very satisfied from these adaptive velcro devices. Also, other nighttime garments are present in the marketing, and maybe they can use only one layer of short stretch bandage over this night pressure garments. But the best ones, in my opinion and in my practice, are the velcro adaptive devices.
Okay.
Night garment is enough. She asks, I mean, when patient use it without used garment during the day. Well, the night garment is not enough, of course, because the patient with breast cancer related lymphedema, not in the prevention period, I'm talking about the treatment. After the treatment, they can use night garments, but in the daytime, they should use their pressure compression garments. Sleeves or other velcro adaptive ones, but when the arms is empty, especially in the during daily living activities, during sports activities, the arms can easily be swollen, and it's not recommended to wear the night garment only. But there are some times that my patients ask me, for example, they are going to a dinner or they are going to a party that they do not want to use their compression garments, very chic, pretty dresses under pretty dresses. But of course, they may not use it for a few hours. But if they get swollen arm after not wearing these compression garments, they can bandage themselves with multi-layer or with adaptive Velcro or with night garments. And in the morning, they will find their arm the same as the day before. We can also help these patients in order not to decrease their compliance to the pressure garments. The same thing is also should be emphasized to the diets. I always tell my patients to eat very healthy, but of course they will eat cakes and they will eat bread and other things. I generally recommend them not to take raffinated flour and raffinated sugar, but if they eat, even they are in the diet period, if they the next day continue their diet, no problem. We have to be flexible as health professionals. We have to modify our suggestions according to patient condition. This is very useful, I believe, for their compliance. And the other is many thanks for fabulous webinar once again. Thank you.
I was just going to make a comment based on our night compression study, and we did a qualitative component in follow-up. And in agreement with Dr. Borman, many of the women felt that using compression at night gave them a little bit of flexibility in terms of those kinds of situations where they might not want to wear their daytime compression. So for a wedding or an event, they could kind of get away with a little bit more by adding night compression to their regimen.
Okay, great. And we have Orsi also with the comment.
I have a rather practical question. It is recommended by international guidelines that the garments are replaced every roughly 6 months. That means that we end up with a lot of used garments. Is there a scheme that anyone is aware of, you know, like recycling garments or like a donation? Because there are worldwide, I'm sure, lots and lots of people who are in need of garments who can't get access to garments. And even though there would be secondhand garments, they could still potentially have use. Is anyone aware of any such scheme?
So when I was in UK, I used to meet few of the lymphedema patients, and according to NHS provides every 6 months compression sleeves. And one of the patients said what she used to do is her compression sleeves used to not get spoiled, so she used to continue to use the same sleeve and send those new sleeves to Africa and other countries. And so I don't know, is there any recycling, but she used to keep her good sleeves and send it over to other countries. So yeah.
Because I used to have a contact to someone in Singapore as well, but that's, you know, like that's just one person. So I was wondering whether there is anything sort of globally that anyone is aware of, but maybe not.
But I would like to comment on this topic. In Turkey, also the budgets are limited to buy 2 compression sleeves at the same time. We suggest them, if their economical conditions are suitable, to buy 2 sleeves, one to wear for when they are washed, one the other to keep it. But you know, they can only buy one of them, and they generally use it up to 9 months. Although we emphasize that the effectiveness of compression garment is not good after 6 months. And in that, accordingly, the used compression garments may not be effective to other patients, I believe, and maybe they should send to recycling to the factories. Maybe they can be used with modifications or other things, but I don't believe that the used ones that are sent to developing countries or other countries are useful because after 6 months, the elasticity is very low and the protection is very low. And even if you wear it or not, it doesn't matter for the effectiveness, I believe.
I don't know. Okay. Do you have any more comments, any more discussion? It was very nice. The recycling idea is interesting. Elasticity is falling down, definitely. But I know one example of using the sleeves very strange fashion for a longer time. It was from early studies from Hakan Borson, and he was changing the shape of the he advised after liposuction for lymphedema to change the sleeve every 3 months. However, it was too costly, so he used sewing machine in his office, and his nurses were suturing with elastic thread the garment every visit. So on his presentation, he shows this garment with multiple sutures there. So I think it is possible. So that's
yeah. In our association, Turkish Lymphedema Association, we are helping people to buy their compression garments. Not so many ones, but at least 10 patients every year. We gave them compression garments with the poor ones, to the poor ones, and we call our members to donate to our association in order to help these suffering patients both economically and from both illness.
On the other hand, just I think that's good discussion for Sigvaris, for the company also, to think about recycling program, because right now in these times it is very good to have label that it is recyclable or there's something that you can give back to the company. I don't know, but it's
good idea.
Just a comment from my side, of course. One of the biggest concerns is of course liability concerns in case something happens. I mean, Pinar has pointed out that the functionality might not be guaranteed after the 6 months of wearing. It's really depending also how the compression wear is treated by the patients. If they wash it regularly like they should, then after 6 months they should be more a little bit more done than if they don't wash them or if they put them on the sun all the time. This is also something that influences the effectiveness of the product afterwards. So we have also considered having the possibility to recycle products, to send them also to other things. Usually it's the initiatives are just initiated by doctors using all the products that they are sending to different countries, but there is always this slight gray zone regarding liability and also concerns regarding the infections that could be brought over and things like that.
There's another question, I think, sir. What about spare apex lymph vessel fissure and mastery reference? I could not understand it.
Yes.
Maybe anyone understanding? What about spare apex lymph vessel fissure and mastery reference? In the surgery, does he mean spare?
I think so. I think so. He's asking about apex lymph node sparing surgery or something like that.
Yeah.
I'm not sure.
In operation to spare apex vessels. Yeah. Actually, I'm not a surgeon, but according to my, as far as I have known, there are different surgical techniques as lympha technique I have talked about, as reverse mapping techniques are very useful for primary prevention methods during the surgery. But to spare apex lymph vessels may be another option, but I cannot anymore comment as I'm not a surgeon. But as far as I know, to save them, to spare them, these vessels may be another option, of course.
I'm also not surgeon. I think, all surgery goes into the direction of sparing lymph vessels, and especially sentinel nodes technique. It's one of the techniques that is sparing lymph nodes and vessels. But specifically, we also know that there's the less injury during the surgery, the better outcome. So but the techniques are developing.
Okay, I think we're more or less done with the presentations. I'm really impressed by the presentations from you, Vincent and Pinar. Very great quality and very informative, and also from the lively discussions that we had with our expert panel. I can also tell you that there was a lively discussion going on in the social media, because a lot of people are following the presentation also in the social media. So we will collect all these questions and maybe send the most important one also to you. And for you, Andrzej, thank you so much for helping me out with moderating this event. And I'm really looking forward for further events in the MOH where we can discuss this extremely interesting topic at the latest when we have follow-up data from Vincent available once again, or new knowledge from the use of compression in lymphedema patients after breast cancer. I would like to thank you a lot and wish you all the best for your day, early in the morning or early in the evening.
Okay.
Thank you so much.
Thank you.
Thank you, Sylvain. Thank you all panel members.
Thank you so much.
Thanks a lot. It was great to be here with you. Thank you. Have a nice weekend.
Thank you too.
Thank you, everyone.